I went down the path of kind of a traditional score-based peer review and brought it to the conference. And it turns out we were talking in this conference more about the score than we were about the case. And it was a very adversarial type of conference. And someone said, that should be a 4. No one should ever miss this. And then I would see people would write down the case number to see, number 1, who is the idiot who missed that case? Or number 2, was I the idiot who missed that case? Right? So in concept, in theory, it sounds like it makes sense. In reality, it doesn't. So at Cincinnati Children's, we completely redid the way we thought about it. We tossed scoring out altogether.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Radiologists. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Today on Frame by Frame Rethink Imaging, we are so excited to welcome back to the podcast Dr. David Larson, the Director of AI Development and the Evaluation Lab at Stanford University School of Medicine, where he is monitoring the performance, ensuring the reliability and the effectiveness at AI. He is living at the intersection of AI and quality. So, over his 11 years at Stanford, he's led education, clinical operations, and performance improvement. Dr. Larson is also a seasoned pediatric radiologist, having served at Cincinnati Children's Hospital and as well at the Utah Radiology Associates. His work in dose optimization, patient safety, and technology has placed him at the forefront of radiology and medical imaging, earning recognition for transforming both education and patient care. Today, we are going to focus on one of his most influential contributions, shaping peer learning as a transformative alternative to traditional peer review. Welcome back to the show, Dr. Larson.
Thanks so much, Chris. Great to be back.
It's so good to have you back. And so, I feel like we just need to set the stage a little bit, right? So at RSNA in 2017, you had a hot topic discussion where you described peer learning as a fundamentally different paradigm from peer review, anchored in feedback, anchored in learning and improvement rather than just numeric scores. Could you unpack that a little bit for us and lay a little bit of groundwork and just kind of get into what makes this framework more effective than the classic score-based peer review model?
Sure, absolutely. Well, and thank you again. It really is a pleasure to be back with you and talking about a topic that I love and has been dear to me for a long time. Maybe we'll start with the beginning of what score-based peer review is. The concept behind that. It's admirable in its ambition, right? In its effort to try to improve quality or at least ensure quality, right? So the concept is for score-based peer review that you have a random sample of cases of your peers that you take a look at and you assess on a score of 1 to 4, 1 to 3. And, for those that are, of misses, essentially, then, just keep track of those. And then it's not exactly clear what happens after that. But, presumably, if someone is an outlier, then they are either, there's remediation or they would be removed from practice, right? That's kind of the concept behind it. And it's a very kind of quality assurance kind of mindset, right? And it actually it echoes kind of what in many fields actually, when they first, focus on quality, they focus on minimizing the errors, right? And looking at kind of the scoring, like you would monitor a machine in a similar way, right? To see how many errors it's producing. And if it's producing too many errors, then there's a problem there. The problem is that's not how humans work, especially professionals, right? Doing work that is very difficult, or at least historically has been very difficult to quantify in that way, but also are people who are dynamic, right? Who constantly learn and who interface with each other and have relationships with each other. And so those same people who are scoring or judging those who are their work are also the same people that they're having a conference with at noon, and they're professional colleagues, right? So that can't be discounted. So I'll tell you a story, the background, when I went to Cincinnati Children's, I was 1 year out of fellowship, and the chair at the time, Lane Donnelly, he gave me two assignments. One was to implement a standardized structured reporting program, which nobody ever implemented before. And then the second was peer review. And those are like the two things that no radiologist wants you to touch. Like, it's like the worst thing that a junior attending can come in to do. Is like, let me tell you how your reports should look like, and we're going to standardize them all. And also, let me tell you about all your mistakes. And so I learned a lot, especially, in fact, I think in many ways being junior was probably an advantage, because I couldn't just come in and I didn't want to anyway, come in and hit people over the head. It's not what we want to do. So I went down the path of kind of a traditional score-based peer review, and we brought it to the conference. And it turns out we were talking in this conference more about the score than we were about the case. And it was a very adversarial type of conference. And someone said, that should be a 4. No one should ever miss this. And someone said, I think that's a 2, if not a 1. Like, it's completely understandable. I'm not even sure if it's a real finding. And they would go back and forth. And, and then I would see people would write down the case number to see, number one, who was the idiot who missed that case, or number 2, was I the idiot who missed that case, right? So in concept, like in theory, like it sounds like it makes sense. In reality, it doesn't. So at Cincinnati Children's, we completely redid the way we thought about it. We tossed scoring out altogether. We had a section that we would review the cases together. We would inform everybody of misses. We added great call cases, and we made it a much more dynamic and learning environment. And that's really the concept behind it. So that moves us from a QA mindset that we talked about at the beginning, where the modern quality doesn't think about things in terms of QA. They don't think about finding the bad apples anymore. A sophisticated quality program, is all about kind of embedding continuous improvement in the process, in the system. And professionals, like, instinctively, we know this, right? And we're actually really good at this if we're given the right environment to be collegial and supportive and constructive, even difficult conversations, even with misses. And so that's what we really tried to do, is frame that in a way that could give feedback to individuals. We could learn together, and if we can change the system to improve the system, then we do that to minimize the chance of making those errors in the future.
Cool. I mean, it makes a lot of sense to me. I mean, the numerical scoring is it's like naturally intimidating to some degree too. But hearing particularly like how people were arguing with each other over it, rather than like getting back to what can we actually do to improve this, it feels so inherently human. And so to tie it back a little bit, I believe we were talking about like those 3 pillars, right? Feedback, learning, and improvement. Could you just start by going through all 3 of those?
Sure. Yeah. So the 3 pillars, as you say, feedback, learning, and improvement. So feedback, when you make a mistake, if somebody, your colleague or anybody in the system, so to speak, comes across that mistake, you should learn about it. I should know about that, right? That should be given to me. It should be done in a constructive way, confidential, private way, and supportive way, right? And so, and then when I'm receiving that feedback, there's a choreography, right? I need to know how to receive it gracefully, right? And there's only one answer when somebody tells me about my miss, and that is thank you, right? We can have a discussion, and I may even look at it, more carefully and say, I'm not sure that's a miss, but it's about the discussion in keeping it constructive. So that's the individual feedback part, right? The learning part then comes as a group of individuals come together, right? And when we look at a case that somebody missed, we don't care who missed it. It doesn't, in fact, we encourage people, just take the names out of it if you can, de-identify it, because, the principle is, there but for the grace of God go I, right? I could easily have been the person that made this mistake. I know whether I was or not, because I would never go into a conference without having already been given the feedback, but it could have been me. And now let's learn about what we can do to not, make that mistake, or strategies that people use to to improve, what they learned, what the experience has taught them. And then improvement is actually something that is really important, and it's been a really gratifying part of this, where sometimes the human is the last person who catches all the misses, and sometimes they don't catch it, and then you look at it and say, well, it was human error. But in reality, there were a lot of things that could have happened to set that up so that it wouldn't have been an error in the first place. So it wouldn't have been missed. So for example, if a technologist has a concern, like, they can raise that. If they don't have anywhere to put that in the IT system, that's an IT problem, right? If a protocol is not done so that the image quality is optimized, and I miss a finding that is more subtle than it needed to be because the protocol wasn't optimized, we need to go fix that protocol, right? If somebody wasn't available because of scheduling, because we didn't have the right expertise available, and I was now reading out of my depth, that's a systems problem, right? So the whole thing is all about learning. So if you get out of the mindset of, let's go and look at that bad apple, right, and say, how many misses did that person make, and change the whole frame to say, let's not worry about that. Let's worry about how we can get together as individuals, as a group, and as a system. Then you start to improve over time. It's better patient care, and quite frankly, it's a heck of a lot more enjoyable place to work.
Yeah, I mean, of course. I mean, I think you have said, right, that traditional scoring can drive radiologists, quote, inward against each other and against practice leaders. I mean, after seeing different departments kind of transition from score to these peer learning discussions, have you observed these sort of, like, either a positive, surprising cultural change within these institutions?
Oh yeah, absolutely. In many ways, it's actually easier. In most ways, it's easier to go from score-based peer review to peer learning than from no peer review to peer learning. Because when you go from no peer review to nothing to peer learning, it's like, really, we have to talk about our misses. But when you go to nothing, to score-based peer review, people they're already trying. These are people who take what seems to be logical and apply a framework. And you're almost always well-meaning individuals. Everybody usually is well-meaning. That's why it's like this Greek tragedy, right? That all these well-meaning individuals that end up, because of their good intentions, end up actually causing harm, because there's fundamental dynamics underneath it that's not accounted for by the way that they approach it, right? So when they now move from that score-based peer review into peer learning, it unleashes what they've been wanting to do really in the first place, and that is to truly learn, review cases, and it changes when a miss. When you put people on the defensive, you are adding insult to injury, right? Inherently. So it's the design of the system adds insult to injury. When instead everybody talks about their misses, and everybody just assumes there are going to be misses and we're going to learn from them, it's a time that people kind of rally around each other. At least it feels like it, right? It feels understandable. It feels like we're all human and we have grace. And the administrators may even have grace and recognize that, that this is a human endeavor, and that's a good thing. And almost always, for the most part, that's the magic of it. That's why it works so well, is because you have people, brilliant people who are incredibly dedicated. But every once in a while, when it doesn't go, you miss it, when there's a missed case, well, then let's learn from it. And if you use that humanity, you use that group dynamic in a constructive way, rather than to find, to kind of ferret out the bad apples, so to speak, it changes the tenor, right? And I witnessed it at Cincinnati Children's, and I've witnessed it at many places, and we hear the same thing when people say they switched over. It takes more work to run a peer learning program, but the culture change is impactful.
Yeah. So you wrote a paper, Transition from Peer Review to Peer Learning, in which you detailed some early hurdles, such as legal discoverability feels, data overload. Which of those challenges do you think are the toughest for, new adopters who would like to take this on in the future? And which do you feel like can be solved by tweaks to workflow or technology or AI?
Yeah, great question. So I think there's kind of two steps. One is getting over the hurdle of, and it's usually local administrators, allowing you to move away from a score-based peer review program into a peer learning program. Because it's a different paradigm. And for administrators who are used to looking at numbers, like that feels really scary and counterintuitive. And it feels like they're also often kind of used to people trying to game the system. It feels like people are trying to game the system. But almost always when, they look into it, if they're well-meaning and have an open mind and have, reasonable trust in their radiologists, then what they find is, number one, lots of other people have done this. And number two, like we're not trying to pull something over. We're not trying to be lazy. We're not trying to get out of something. We're trying to free ourselves from the shackles of this, quite frankly, toxic and poisonous construct. It wasn't intended to be that way, but it's just the outcome of it, right? So it's having that's the first hurdle. And once you get over that, then it does take more work. And that's usually the hardest thing. Is it requires somebody to actually go through the cases that were missed. It requires to look at them, assess them, with some consult with people. It requires providing feedback in a confidential and supportive way. That actually takes time to do that, right? It requires preparing the cases for a conference and then having that discussion, everybody coming together and meet together and review. So it's really about the time. And I would say we could use additional tools to help with a lot of kind of the details of gathering that information and keeping it confidential, right? That most tools are not able to do that. And when they do, quite frankly, a lot of the IT developers, they don't understand like some of those nuances. They don't understand like how critical it is to never, ever accidentally reveal the identity of the person who made the miss in a conference, right? So you have to build a tool that will facilitate that. So yeah, those are the main things, but they're totally doable. And if you streamline it, it actually doesn't take a whole lot more time, and it tends to be like some of the most beneficial learning that practices do. You can we've had practices who've got CME credit for it. Practices where people come in on their days off to go to this meeting because it's their most valuable meeting of the whole practice or the whole in their department.
Do you have any advice for folks who would be looking to streamline like that?
There are some IT tools that can help. For one, I'd say mainly if you're looking to streamline or if you're looking to do anything with your peer learning program, there are lots of other people who have figured this out. We have a committee at the ACR. It was founded by Jen Broder, the peer learning committee. Jen Broder started it at, she's at Leahy Clinic, and now Rich Sharp, who's done just a tremendous amount of work first when he was in Kaiser in Denver, and now leads this nationally as he's transitioned over to Mayo Scottsdale. And there's a whole community around this. Lots of people who have gone through the journey of having those conversations with their administrators, of setting up something that is feasible, of working through all those, all kinds of challenges. And the community is like unbelievably willing to help. Like these are the people who have like made this their crusade, right? This has been their passion for so many years. And to see it come to light, there's nothing that we love and they love more than somebody calling up to say, "Hey, I'm trying to set this up. Do you have any advice?" Like, absolutely, we'll get you started.
I love that. And so what would you say for, like, how would you adapt a peer learning design for like a smaller, more rural community hospital with like limited subspecialty coverage versus, a larger academic center like where you are at Stanford?
Yeah, great. So first of all, good question. And we get this a lot. And I would say, that's the beauty of peer learning is it's very flexible. The concept is very flexible, and it should, almost by definition, be adapted to your local environment. That's what peer learning is all about. It's you learning along with your peers, right? It's reinforcing that relationship. It's improving your performance in the construct that you have. So, for example, at an academic department like radiology, one challenge we have is we don't have one peer learning program. We have 11 peer learning programs, basically, one in every division, right? Because it doesn't make any sense for me as a pediatric radiologist to go to the breast breast imaging, peer review conference, or, for musculoskeletal to come to IR, right? So at the smaller sites, I'd say, or any site, tailor it to what makes sense for you. So we had this really wonderful presentation. That was I practiced from, I believe, kind of the Northern Virginia and West Virginia area. Very small practice. And they would get together once a month and they would just keep track of their missed cases. And they would just come and have a list, and they'd go through and pull it up on their packs, and they'd, have maybe a handful of people, half a dozen people, and just go through their missed cases. And great. That's it. Because that's plenty to get you talking about, here are things that we missed here, and then they would also provide feedback. They let people know, when you're in a small group, you can't de-identify it anyway. So you don't necessarily need a great big, de-identification system and data management system. You just let people know. It's a culture thing, right? You let people know about issues that come up. You have a discussion, and then you just come, with an open mind, and you share and you learn and you continue to try to get better. That's what it's all about. We've also had environments where you've got a handful of, or one or maybe two subspecialists within a larger practice that they're kind of the only subspecialist, right? And so they want to have a peer learning experience in their subspecialty, and they've gotten together in a regional area, and they come and they share their misses as well. And so it all works. It's mainly about who are your peers, who you're learning from. Get together with that group and learn from your misses.
Yeah, and so this follow-up question may be a bit, you might have already covered this, so forgive me, but so. How would you structure these meetings? Or how would you explain to someone? I feel like you just covered it in some way, but to dig our teeth in a little bit more.
Yeah, so I've seen it done, a handful of different ways, but for the most part, they're pretty much the same. The first part, at least at first, when you start the meetings, usually you kind of have to have a preamble to say, okay, this is what, peer learning is about. Here are the ground rules. We're not going to find fault. We're not going to blame. We're not going to try to identify. We're not going to, talk about how bad this, that's what we're not going to do. What we are going to do is focus on learning, and we're not, we're going to focus on how each of us individually can improve, right? So that baseline, and then you just dive into cases. Say, here's the first case. And, often what we find is there's the perception cases, and then there's the diagnosis cases. And perception cases is kind of we would call it our missed fracture clinic. It's just, here's a fracture. Oh, whoops. Oh, yeah, I can see how you can miss that. Okay, here's another fracture. Oh, shoot. Okay, I can see how you can miss that. Yeah, and it's actually really helpful. It's kind of I likened it to, I don't know if you've ever seen those bumper stickers that says, start seeing motorcycles, right? Have you ever seen those? The concept is, if you just process this, and you see enough of these, right? Just that repetition of, I know it's a lot of the same type of missed cases, but it reinforces that now when I go to the reading room and I see that, distal tibia fracture that is that's oblique, that's just right overlying the fibula, because you can easily get fooled and think it's the overlying fibula on that lateral view, but it's actually distal tibia fracture. Okay, now I look more carefully for that, right? So that's the first part. And then the second part is the interpretation cases. And those are usually longer discussions, and, people weigh in, and they give, this is where you start to see a lot of the expertise come out, where people who have more experience will kind of identify, learning aspects, how, they can, what they do to try to, or how they would approach it, right? And what they would do to try to have to make sure they come to the right conclusion. Or sometimes it's those cases are also the ones that really elicit the kind of process and systems improvement part. It's a person who read this, it turns out was, there was out of their subspecialty, and, they didn't have extra coverage. Great. That's a good conversation starter for subspecialty, or for the systems issues. So it turns out it ends up being a bit organic. It's structured in that it's all case-based. That's the key. It's got to be case. It's about actual cases. And the fun thing to watch is the great calls, right? Where you put in a case, you don't tell them it was a miss or a great call. You just put it in, and someone says, whoa, this is a tough case. I can totally see how they missed it. And they say, well, actually, they didn't miss it, right? Somebody caught it. It's whoa, that's fantastic, because the material is the same, right? It's whether you actually caught it or not. If you could have missed it, then it's a great peer learning case, right? Because the only difference between it is the person happened to catch it at that time.
Are there any cases or specifics that stand out in your mind where you were like, wow, holy crap?
There's one radiologist at Cincinnati Children's when we started it, Chris Anton, that would constantly have these amazing calls. Like he does a lot of pediatric musculoskeletal imaging, and everybody knows that he's brilliant, and he's just very down to earth person, but he's got a great eye. And we would just have these impossible cases, and I'm trying to think. There are a lot of like those subtle musculoskeletal fractures, like it's the tiniest of a hint that you really have to squint and make it big. And you just see them, and it's just so enriching, right? Because if you think about like all the learning activities you do in radiology, there's nothing more impactful than something that it could be you, right? It's like this is my practice. This is a case that I just happen to be not the one that clicked on it, but somebody else clicked on it. And if I had clicked on it, I would have gone down the tubes. You got my attention, right? I may doze off in the lecture, at the CME course, but this one that's like going to be my next case that I'm going to like fail if I don't, pay attention. Like, and it's in a constructive way because it's free. I'm not going to miss it. I can't hurt anybody because it's already done. But now we can learn from it. So it tends to have like it was. It ended up being like one of the most, in many places it often is, one of the most popular conferences. The trainees actually really appreciate it too. It's a really great exercise for trainees because number one, they get to see that their attendings aren't perfect without, having to be individually humiliated, right? And number two, they also get to see, holy cow, some of our attendings are amazing, and I need to up my game on both accounts. I need to up my game.
We've talked about how the goal is not to score error, but rather to learn from error. But are there metrics that we feel or that you feel are important, whether or not it's like a KPI or an indicator? Is there anything else that you're trying to track to process that these sessions are driving change, or is it truly just like rooted in conversation?
We really emphasize that the main measure is participation. What you're trying to do is foster an active, healthy, participatory dialogue, right? Where you have people who are active in submitting cases. There's psychological safety. So that's one measure of psychological safety is when people are submitting cases. In fact, I would say the best sign of a mature peer learning program where there's true psychological safety is when they submit their own misses. Right. Then they clearly now they're comfortable that it's not going to be used against them. Right. And then otherwise, it's also, you can look at the improvements that come out of the program. But in terms of, calculating, some KPI about some performance KPI, not right now, not at this point. Now, I will say, well, actually, I'm going to say that with a caveat. Two caveats. One, there's what you often see with a peer learning program when it becomes more mature is you sometimes see a campaign. It's what some people would call it, right? Where there's a theme. These themes start arising. You start to see misses in the same types of misses. So one that was really impactful for me, this was incredibly impactful, was at Cincinnati Children's Hospital. We had there are several cases, actually 3 cases, where the PICC line, the PICC is a peripheral indwelling central catheter. So it's pretty common that people get this catheter for chemotherapy infusion or something that lasts for a long time. And so the catheter tip, you want to put it right above the heart. It goes centrally, but you don't want it in the heart, right? And when you do, you can actually perforate the heart, the muscle wall, and then it causes a hole, and then blood leaks out, and then it gets restricted by the pericardium, which is the sac around the heart, and then you can have real problems. So there's actually a patient who had died from a cardiac tamponade and then 2 patients that experienced cardiac tamponade from myocardial perforation from a PICC line, which these seem to be incredibly innocuous, but actually they can be really dangerous. So we presented all those cases together. Well, here's the other problem. Because they seem to be so innocuous, people often don't take them seriously. It's like, nah, it's where the PICC is noted. Like, well, no, actually, it needs to be in that specific location. That location needs to be defined. So Neil Johnson was a pediatric radiologist, interventionalist at Cincinnati Children's, led a huge campaign to really refine exactly how those things should be managed and how they should be reported. We presented a cine image of a heart beating with that PICC line hammering into the muscle, right? And it's like, oh, I see it. And then we presented, because at first, they'd say, oh, we're presenting PICC lines, there was rolls their eyes. Let me tell you a little bit more. We present that, and then we present 3 cases, one of whom died. And this was earlier. And then we present like how well we're reporting those. And the answer is we're not reporting them well. And you come out of that and say, wow, that was, talk about a change agent. After that, then we started monitoring how well those were being reported. And they're much more carefully reported. I mean, that certainly in me, made me think about it very seriously, right? So when you have those campaigns, then, they can actually drive improvement, dedicated improvement over time. You start to see that.
I hate getting into financials, right? But let's talk about needing to make a business case for the C-suite. Hospital CFOs, I feel like, are naturally going to ask for, some sort of ROI or some sort of proof in the pudding when confronted with a quality initiative. How would you frame a business case for peer learning if leadership is so focused on, the dollar value?
I personally struggle with this one because it's hard not to, quite frankly, to get a little emotional about this, because I think if your purpose is to make more money from peer review, I think you're approaching it wrong. Personally, I think you're in the wrong business. I think that we ethically, that is actually the core of what we do, which is continuous improvement of excellence in the care of our patients. I would say that it does have, it's continuous improvement. So I would say to any CEO, if you have any care at all about continuous improvement, well, there you go. What often happens is you find that workflows were not managed well. That gives you an opportunity to change a workflow, right? Or manage it. You find out that there are other problems that you were putting patients at risk, or even talking about the legal liability. I mean, there's all the cases that you can never quantify that you didn't hurt people, you didn't get sued because you're keeping people at the top of their game. It's also the culture. It creates a better culture to recruit and retain people. It decreases burnout and people checking out. So I'd say, I guess I would ask, maybe, you can't really ask this, but I'd be tempted to ask, what is the dollar denomination that you put on your culture as a CEO? And if your answer is, well, we don't care about it, it's all dollars, and it's like, well, why are you in healthcare? I know that's a bit, maybe a bit cynical, but whatever dollar value you put on culture, use that number and apply that to peer learning.
I think that's a great answer. That's a great.
Well, I hope so, but I guess I'm a little cynical.
It doesn't feel cynical to me, right?
It should be a great answer. That's why we're here. And it's like the beauty of peer learning is actually, when people just let go of there's so many apprehensions. Oh, we're not going to have we're not going to have the scoring anymore, and it's going to take time. And now people, may, slack off. It's like the sky is going to fall, and the sky never falls, right? And those score-based peer review programs never did any good in the first place, and they did harm, right? So actually the benefit is going to be, you're going to replace the thing that was doing harm and already taking time and making people hate you because you're pushing this. And that's the irony. The harder you push, the more they hate you, even if you're doing it for good intentions, right? Just because it's constructed to be poisonous, not intentionally, but that's just the outcome of it. It changes that into a constructive and a collaborative relationship. So would you prefer to have a more collaborative relationship with your radiologists? Put a dollar value on that as well.
Yeah, in fact, I think in your AJR article on peer learning, you were highlighting the importance of sharing insights as well with referring clinicians too. Um, can you talk a little bit about the peer learning discussions you've had and like whether or not is that improving interdisciplinary trust or like how are you capturing that impact?
Yeah. Oh, it's great. Great question. So, y- really, where it starts, I mean, the peer learning conference, you generally don't have people outside the group come to peer learning program because it's all about your peers. But you often will have representatives. Hopefully you have radiologists who have relationships with each of your major referring clinician groups, right? And so that's where. For example, actually, I'll go back to what Neil did at Cincinnati Children's. He was working carefully, with the surgeons and with the hospital leadership and nursing administration, for example, in managing PICC line, right? So all that cross-disciplinary effort, and he was going to meetings, and they were coming up with, design of how things should be managed and education components and feedback, like all those things are happening across the whole health system. Well, now when you've got a peer learning program, you've always got a conduit to say, we will come and take the feedback that you just gave us, or take this initiative that you're working on to improve care, and we'll put it into our peer learning program. So you've automatically now, you've opened the door to invite feedback on difficult discussions that otherwise are really hard to have spontaneously or ad hoc, because no one likes to come into the meeting and to say, oh, well, we've got, the orthopedists are now complaining again, right? That ends up being kind of the way it feels. And it's like, no, we've already changed the mindset. When you walk into this room and you are in this meeting, the mindset's already different. The mindset is, we're here to learn what we can do better. Oh, the orthopedists have something that they think we could do better? Great, let's talk about it, right? Oh, yeah, the oncologist would like these measurements because when we don't put these measurements, then it causes problems. And you've illustrated that, what was the outcome of not having that? That makes a lot of sense. Okay, we can work on that, right? So that's where you end up seeing, it ends up feeling organizationally like the Department of Radiology is receptive, because it's designed now to be receptive, because you have a conduit of receptivity, right? Whereas before, maybe we can try to be receptive, but we don't have like a construct to put it in.
Dr. Larson, with health system consolidation, remote workflows, and AI reshaping radiology, the peer learning landscape is evolving super quick. Looking to the future, what is your vision for peer learning 2.0? Do you think we could, start to see a national learning framework? Where do you see things headed?
So I'm really excited. I'm bullish on this. If we do it right, it's actually probably you're going to see it go both ways, I think. And it's going to be sad to see the places that don't and have to learn the hard way. But I think there are going to be some places who get this right. So the first question is like a national peer learning program. A lot of people have offered that and thought about that. I thought about that at first, but pretty quickly started to realize, peer learning is mainly about your relationships, right? It's about the content. That's part of it. But it's also that, again, that kind of fear that like, this could be me. And it's also about my peer and my colleague. And it's somebody I know who trusts and is giving me feedback on a case that I very well may be seeing in the future, right? So it becomes very personal when it's a local program. And I think for the most part, these programs will stay local. I think a national peer learning program only will emerge to the extent that it is reinforcing a community, because really that's what peer learning is about. It's about community, right? So that's my opinion on that. I think what we're going to see is the integration of AI and peer learning, and I think there's a huge opportunity for that. If programs that have a great peer learning program in place, again, already have that conduit. And now when you can add, quantitative assessment, you can add a lot more cases that are being brought to your attention, the learning can go way up. And the second thing is that I think that in what's going to happen, again, with enlightened practices going forward with AI, is that it will provide the opportunity for cases to be routed to the experts more quickly, to get second opinions, other people weigh in, to have greater sophistication and greater transparency about the clinical content of what's coming to us, about prevalence, about feedback, about, if we have, our positivity rate of our pulmonary embolism cases is like 0.5%. Let's have a talk with the emergency physicians because we're over ordering, right? I think we're going to see a lot more information that's coming out, and we can use that if we decide to become better colleagues, to operate more as a system and more as teams, right? If we can learn to move beyond being isolated, independent operators who can never be told anything, and never work with anybody else, to actually working together as a team, I think those are going to be the practices that thrive, and they're going to be practices that people are going to want to work in if they do it well.
We've just barely touched on the AI stuff this episode, which honestly, talking about radiology and AI, I don't mind taking a small little break from it. But since you brought it up, as AI tools are getting more and more prevalent, they're increasingly flying outliers and errors. How do you see the pure learning complementing or contrasting with algorithm-driven feedback?
I would say whoever is developing anything that's providing feedback, whether you are a radiologist or you're a data scientist or an informaticist, go and read the literature. Understand what a score-based peer review system is and what it does. What feedback that's not done in a really thoughtful and careful way, what that tends to do, and compare that to what you can do if you're really thoughtful and careful, and if you're trying to reinforce the culture. Those, as you build these systems, you will have an impact on the culture, whether you know it or not, or whether you care or not. And that culture, it has antibodies, as it should. It's self-protecting, right? And so if you try to implement feedback and it's done even in a way that's just slightly insensitive, like it's just not really careful about protecting confidentiality, or it's just there's a risk that potentially it could be done in a negative way, like you're going to have significant negative impact on what you're trying to do. So I would say just be careful. Fools rush in where angels fear to tread. You are working in dangerous territory. It's human psychology and sociology that is really unwieldy, and it's understandable, mainly if you just be a human and think about it as a human and stop thinking about radiologists as widgets and machines. If you do that, actually, you'll probably be in a lot better place. But not everyone will do that. They'll implement these things in some ways. They'll do it wrong. And so then I encourage the rest of the community, the radiology community, to call that out, to not accept this type of sloppy and, unthoughtful, not whatever that word is, not conceived or not deeply thought through design. Have high expectations of the people who you're designing your systems, and don't accept, sloppiness. The technology may be wizardry, but it may look like it's magic. But if it has a negative impact, it doesn't matter. It's not thoughtful.
Yeah, some very wise words there. That's it for today. Thank you so much for joining us here on Frame by Frame. Once again, Dr. Larson is the Director of AI Development and the Evaluation Lab at Stanford University School of Medicine. Dr. Larson, it has been my pleasure to have you back, and I can't wait to talk to you again.
Awesome. Thanks so much, Chris. It's been a real pleasure for me too.
Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.